Hello everyone, my name is Dr. Satyajit Chauhan. I am a fetal medicine specialist. I am practicing presently in Assam, Guwahati, in Pratiksha Hospital. It's been a long time I wanted to speak on a topic called the fetal echocardiography, which is very close to the heart of every fetal medicine specialist, radiologist, and the sonographer who are practicing the fetal ultrasounds. So, whenever you scan a fetus, maybe a normal fetus, or when it is referred as a cardiac anomaly, we always have a tendency to jump into conclusions. But I suggest whenever you get a referral for the fetal echocardiography, you should always step back. What I mean to say, that you should stick to the basics of the fetal echocardiography. You should keep in mind that there is some problem in the heart, and if I am not following all the steps of the echocardiography, then we may not come to a conclusions many a times. So we always start fetal echocardiography by establishing a situs. So there are different ways and means of establishing the situs. What I follow is that I align myself along the lie of the fetus and see that my situs and the baby's situs are similar or not. And then from the abdomen, then we move little cephalad to the four chamber view, and then gradually from the four chamber view, we are not directly focusing on the four chamber. We should start looking from the spine, then aorta, pulmonary veins. I'll explain in subsequent stop. Then four chamber to three vessel trachea view, alveoli view, RVOT view. Then we look at the pulmonary veins mostly in color and grayscale, and also we need like power Doppler to establish the normal right subclavian artery in most of the instances. However, with the normal color Doppler also reducing the PRF, we can see the normal right subclavian artery. So let's start. So as I mentioned that it should always start from this abdomen. So in the abdomen you can see that this is the abdominal circumference. We can see the aorta. Here you can see the aorta, which is just lying in front of the spine and towards the left, and this is the IVC, which is lying right up and towards the lateral side. So this is the normal appearance of the fetal abdomen. Then we can put another picture of the heart, and we can see that the heart and the stomach is pointing towards the same side. But this is not the way to establish the situs. I have told you that I align myself towards the same lie of the fetus, and then I establish the situs. Because in cases, if you practice this, then in cases of situs inversus totalis, you can miss the diagnosis, because in situs inversus totalis all the visceral structure and the thoracic structures will be in the same directions. That's why we must follow the steps to establish the situs. Next, we obtain the four chamber view, but we directly will not jump into the four chamber directly. We'll start with the spine, then aorta, then we'll see this is the pulmonary veins which is draining into the left atrium, and left atrium lead to left ventricle via the mitral valve, and this is the right atrium, this is the tricuspid valve and the right ventricle. Now another important point in this view is to establish the which one is morphological right ventricle, morphological left ventricle. So this tricuspid valve always have an apical insertion compared to the mitral valve, which is very pathognomic for the right ventricle. At the same time, if you look at the apex of the heart, this is the left ventricle, and you can see a muscular structure. This is called the moderator band. This is again indicative of the right ventricle. We also see a connecting space between this, which is called the foramen of a veil, and blood flows from the right atrium to the left atrium. So this is why it is important, because 60% of the cardiac anomalies are seen in the four-chamber view. Next, moving ahead, is our three-vessel view. Now the three-vessel view, it is called three-vessel view because we see three vessels here. In the three-vessel view, the important thing is to look at the arrangement of the vessels. You see the pulmonary artery, aorta, and the superior vena cava from left to right directions, and this arrangement is slightly in an oblique fashion. This is the normal pattern of arrangement. Why it is important? Because in certain cases of transposition of great vessels, these three vessels can be seen, but the arrangement will be more kind of a transverse rather than this oblique fashion of arrangement. That's why it is important that we look at the arrangement of the vessels. Second, we must look at the size of the vessels. Usually the pulmonary artery and the aorta are of equal size, but in certain cases like the aortic atresia or aortic stenosis, or in cases of coarctation of aorta, this aorta can be smaller than pulmonary artery, which gives an idea that we need to look at the aorta more carefully. There are certain other conditions where the pulmonary artery can be enormously enlarged, as in case of absent valve syndrome, absent pulmonary valve syndrome, or in certain cases the pulmonary artery can be small, either in cases of pulmonary stenosis or pulmonary stenosis as a part of tautology of Fetal. Also, we should look at the number of the vessels. Usually we see three vessels, but in certain conditions there can be an additional vessel somewhere here, which is the persistent left SVC. There can be some vertical veins also can be there, depending upon the certain cardiac anomalies. Next is the three-vessel trachea view. Again, in the three-vessel trachea view, we should look at the number of the vessels, the size of the vessels, relation to the trachea, and also you should try looking at the thymus. Now, this picture you can see that pulmonary artery continuing as ductus arteriosus, and this is aorta, transverse aortic arch joining here, and it is normally on the left side. This joining is left side of the trachea. This is the normal pattern. Here you can see this is the transverse aortic arch and this is ductus arteriosus. So in this picture, from this picture we can understand that in this view we are looking at the transverse aortic arch. So we are trying to rule out or suspect the aortic arch anomaly. Now what are the possible aortic arch anomaly? If the aorta is very small, or if you don't see aortic arch joining here, then ductus arteriosus. The possibility are like there can be coarctation of aorta, there can be interrupted aortic arch, there can be any other like tubular hypoplasia of the aortic arch. So there are certain other conditions also be there where these views can be abnormal. That's the reason this view is also very essentially important in the basic echocardiography. One important structure which usually we do not focus is the thymus. It is described by Professor Ravi Chowdhury long time back. In this view, we can see that this is the thymus. In this picture, if we draw the diagram, it would look like this. This is the thymus. Now, why do we need to look at the thymus? If the thymus is hypoplastic or there is agenesis of the thymus, aplasia of the thymus, it is strongly associated with 22q11 microdeletions, which is called DiGeorge syndrome, and it is clinically very significant. That's the reason we should always try looking at the thymus. If not by quantitative means, at least by subjective ways, we should always look at the thymus. The relation to the trachea, why I have mentioned that usually you see this ductus arteriosus and transverse aortic arch should join to the left of the trachea. But you can see this V pattern is also seen, but this is not normal. This is on the right side of the trachea. So this happens when the right ductus arteriosus and right aortic arch are present. Then it forms a view, but forms a V shape, but on the right side of the trachea. Sometimes we can, in the three vessel view, we can get an U-shaped pattern where the right aortic arch and the left ductus arteriosus are present. It joins behind the trachea. It does not form a ring, but it forms an U shape, which is and very suggestive of right-sided aortic arch. This view we can see, this is a double aortic arch where both the left and the right aortic arch, it encircles the trachea and forms a ring, which is very, very significant and from the clinical perspective, because this baby has to be delivered in tertiary care centers. So now moving on to the outflow tracts. The first important outflow tract is the LVOT. You can see that this is the interventricular septum and there is a continuity with the aortic origin. This is called the septo-aortic continuity. This is important that we must see an angle like this at this point of time, because when there is an overriding of the aorta, this angle will be lost and the aorta will be sitting on the top of the septum, as in cases of tautology of Fallot or your conotruncal abnormalities and all. Here also we can see the mitro-aortic continuity. This is the RVOT view where we can see the right atrium, this is the tricuspid valve, and this is the right ventricle, and from the right ventricle we can see a clear-cut pulmonary artery arising. This is the right pulmonary branch. This right pulmonary artery continuing as ductus arteriosus, and it joins the descending aorta. The difference between the right RVOT and the LVOT, that is aorta and the pulmonary artery, is that aorta does not branch immediately above the valve, but pulmonary branches immediately above the level of the valve. This is the color flow. Here you can see the proper filling of the ventricles from the right atrium, from the atrium till the apex of the heart, and there is no flow, there is no bidirectional flow across the septum should be seen. This is the three vessel view. We can see the pulmonary artery and the aorta both in the same color because it has a forward direction, whereas the SPC is in opposite direction because it drains blood from the upper part towards the heart. So the direction is from up to down, whereas this direction is in a forward direction. That's why it is blue and this is red. This is the three vessel trachea view. When you try obtaining the color flow, you try that the aorta and the four chambers should be adequately filled. Here in this you can see the entire aorta is completely occupying the color, and there is no overriding or there is no Y-shaped pattern of the aorta. There is no flow across the septum, which is very, very reassuring that there is no VSD, there is no overriding of the vessels. This is, I have shown you that here you should keep one thing in mind, that this is the red direction. If you look at this color coding here, because blood is flowing from the right atrium to right ventricle in this direction, that is going up, so the direction has to be red. Again, from right ventricle it is moving in forward direction, which is blue, so it has to be in blue directions. This is pulmonary artery, right pulmonary branch, and the aorta, because all these are moving forward, so the color is blue. The pulmonary veins, here you can see the pulmonary veins, both the pulmonary inferior pulmonary veins is draining right into the left atrium. And another important structure we do see is the normal right subclavian artery. This is the normal right subclavian artery arising as a branch of the brachiocephalic vessels, and then it courses in front of the trachea. This fluid filled trachea this is, and this usually have an S-shaped cross, and it reaches the right arm. To show you more precisely, you can see this is pulmonary becoming ductus. This 3-vessel view, right? This is the point where the transverse aortic arch and the ductus is joining, okay? And you can see this is arising in the first branch and then going into the right arm. So this is the normal right subclavian artery. This is the trachea. It is passing in front of the trachea. In cases of aberrant right subclavian artery, the origin will be from, as the fourth branch it arises, the aberrant right subclavian artery arises as the fourth branch from this point, and then it runs a straight course behind the trachea. So this is the grayscale views, 4-chamber LVOT, RVOT, 3-vessel trachea view. In the color we can see the same, okay. So to conclude, this is the final video where you can see, starting from the abdomen, you can see the moving spine, aorta, pulmonary veins. This is the 3-vessel view. This is the thymus, 4-chamber pulmonary veins, left atrium, left ventricle, and then from there we'll turn the transducer towards the apex to open up the left LVOT, where you can see the septo-aortic continuity. You can look at the valve which is appearing and disappearing, and there is no branching immediately above the level of the valve, indicating aorta. Then we turn the probe in the other direction to open up the RVOT, or the pulmonary artery. You can see the pulmonary valve, right pulmonary branch, pulmonary artery continuing as ductus arteriosus, joining descending aorta. Switch on the color. Again, from the stomach, you can see an adequate flow in the 4-chamber. There is no flow across the septum, so no VSDs. This is the LVOT view, 3-vessel trachea view. This is the LVOT view which I have shown. There is an adequate filling of the LVOT, and there is no Y-shaped pattern indicating of overriding or VSDs. This picture already explained. This is the RVOT view, or the pulmonary artery view. You can see blood flowing from right atrium, right ventricle. This is pulmonary artery, and this is the pulmonary veins. You can see all the 4 pulmonary veins here. Finally, the last part of the echo is we must obtain the NRSA view, that is the normal right subclavian artery. This is passing in front of the trachea. This is the trachea, fluid-filled trachea. Thank you so much. Thank you so much for listening, and please do let me know if you need anything to describe. I'll try my level best to work on it and to share my knowledge to all of you. Thank you once again. Thank you so much.